I've been doing some work with the Health Quality and Safety Commission over the last years, and more than anything, what people have said is, how do we get the inter-eye data into care planning? So we've got this great inter-eye data set, and clearly that was a fantastic demonstration of what could be done with this data, which is a huge leap forward. So the question is now, how do we, as those of us that see eye-to-eye older people on a daily basis, how do we get this inter-eye data into our daily care planning? So let me this is just basic. What is a care plan? It's a coordinated problem-solving approach. It's basically documenting what we're going to do based on what we've assessed. Now, it's simple stuff. This is not rocket science. But I find that as a clinician, and most clinicians, we struggle with care planning. We struggle with care planning because it can become an exercise rather than a dynamic piece of work. And one of the things that was really clear to us when we went around, particularly we did a great session in Christchurch, and some of you might have been there. And one of the things that I've heard from people over and over again and seen in practice, because I've asked to see some people's care planning as well in part of this process, is we've got 20-page, beautiful looking care plans that never get looked at again. And they're beautiful. They are so gorgeous, and they're 20 pages, but we're not actually using them dynamically. What I've heard from people, and what I do know in practice, is that we make them for the auditors rather than for the patient and for the resident. And I think that it's a challenge. It's a real challenge. But how do we take that 20-page document and make it a daily usable kind of thing? And now what a lot of people do is they have a short-term care plan and a long-term care plan, and that's one way of getting around that. But I don't have a lot of the answers, although I do want to say how we can kind of examine and look at all this great data that we have from Inter-Eye and use that in our care planning. So this is the AIS-related residential care services agreement. Those of you that work in residential aged care know this quite well. This is what's required for care planning. It has to be done within 3 weeks. You've got to consider the experiences and the choices of the resident. You've got to have their input from their family whānau. It needs to address deficits and personal preferences, individual habits, so it needs to be individualized. And it also needs to address personal care needs, healthcare needs, rehab needs, maintenance of function, and also palliative care needs. So that's what we're obligated to do based on the contract. This is what the health and disability standards talk about with care planning. They need to be individualized, accurate, and up to date. Now, one of the tricky parts about care planning is there is a lot of evidence-based practice out there, and yet it needs to be individualized. And that often creates a tension in that if I know that somebody has congestive heart failure, for instance, there are certain evidence-based things that I need to do. How do I make that individualized? Does that make sense? And I think that that's one of the tensions that we're struggling with care planning, is that it doesn't mean you have to rewrite the care plan differently every time you do it for the same person, for different people with congestive heart failure. Because there is actually an evidence-based practice for congestive heart failure. It means that for that person with congestive heart failure, you've taken into consideration who they are and also included the evidence-based care planning that's out there already. So that's one of the tensions, is we don't want you to make it up every time, is what I'm trying to say. But we do want you to do evidence-based practice. The other thing that the disability services would like is you need to demonstrate service integration, which is in residential aged care is sometimes a challenge, as you all know. It's sometimes difficult for us to get services to integrate with us. So it's not just that we're integrating with other services, it's how do we get them to come out and see us. So that's a whole nother discussion. And is it communicated in a manner that is understandable to the consumer? Now this is also a tension, is that we are often writing these for the auditor, and yet it's for a family. Do you see how complicated that is? And a family, I will tell you, is not going to read 20 pages. So how, again, another tension in care planning that I think we could probably think about and move forward with. So inter-I and care planning, the Health Quality and Safety Commission, again, what I've talked about, the care planning and the inter-I, it turned out to be the thing that people talked about all the time when we did this consultation. So a few of the challenges. Inter-I data is often only updated every 6 months. Now, Bridget and I were just talking about this. I think that one of the things that we could work better with the sector on is that they can upgrade those inter-Is a lot easier than what they think now. But one of the things is we're getting the inter-Is every 6 months now, which is great. But often people's condition changes dramatically and that inter-I should be updated. But I think there's a wee bit of a psychological block for some of the inter-I assessors, like, oh, it took me forever the first time, why would I do it again? When I don't think it's as complicated as we think it is. The inter-I subscales are not routinely used instead of other similar tools. And I hope that if there's any other take-home message today, that's the take-home message. We need to use the subscales instead of bringing on the Waterlow or whatever else we're going to use, or what other depression scale you're using. Use what we've already done rather than redo it. Non-inter-I trained providers don't understand how to use the data in the subscales. I work in primary health care, I'm a nurse practitioner, I prescribe. I can guarantee you the GPs I work with do not look at inter-I. This is from a research study that was done in 2006, and I thought it was quite interesting because it kind of addresses what I'm seeing in New Zealand as well. What are some of the issues that makes it so that care plans are not translated into practice? So we've written them, they're beautiful, but they are not translated into practice. And one of them is the length of the care plan. And they're very long. The other thing is that we often I'll see nurses write routine things that we do just as nurses over again. So instead of saying, we'll review OBS, they say, I will do the temperature, and I will listen to the chest, and I will do this, and I will, instead of, I'm just going to do this, I'm going to do the COPD pathway, or whatever we're going to do. So that would be really clear if you had care guides or something along those lines that said, this is the COPD pathway. The other thing is, we need to have these in some way so that the HCA can understand them. So the HCA can really be a partner with us in our assessment. So that I can say to an HCA, and I do this when I'm working in aged care, do they seem like they're struggling for breath? It's that kind of level for the HCA. They're not asked to assess, but they certainly know this person. Did this person have more trouble dressing than they normally do? It's that kind of thing. The other thing is the redundancy in interventions relevant to multiple problems. So this is an example. Observed for signs and symptoms of hypoglycemia or hyperglycemia for 3 different problems: diabetes, nutrition, and falls, right? You don't need to say it 3 times, you only need to say it once, okay? And then there's a variability in the language used in the care plan problems. And again, I see this that's kind of as a surrogate for individualized, but that's not individualized. So we need to think about that. And the other thing, depending on where I go and where I work, the care plans are, we did a study on end-of-life care a few years ago. And what I was interested in is I needed to know where the EPOA and advanced care planning documents were, and in every facility I went to, they were all, they're in a zillion different places. Because we all do things differently. It's the same in primary care, it's the same at any hospital you go to. It is how we do health care, but that does make it very, very difficult for particularly a GP that might go to 3 different facilities to figure out where to get this information, just for instance. One of the things that was recommended for best practice, and this is achievable. So with care planning, it's got to be that smart, that smart care plan. So it's got to be specific, it's got to be measurable, it's got to be achievable, it's got to be realistic, and it has to be timed. So you can't just say, I'm going to make Mrs. Jones feel better, or I'm just going to make Mrs. Jones be a little bit more active. It's like, of course, that's not going to be work. What we need to know is Mrs. Jones can now walk 3 meters And in the next time we look at this, we're going to either maintain the 3 meters, which for a lot of the people that we work with, that's a huge thing, or Mrs. Jones will then be able to walk 6 meters, rather than 3 meters, because, and I'll talk a little bit about the intervention. So that's the goal, but the question is, how are you going to get her there? Okay, so that's the other question we'll talk about. So, achievable. Understandable. We need to not use jargon and not use abbreviations that other people don't know, especially if we're giving these to caregivers or if we're giving them to family. We need to make sure that that's very clear. Comprehensive. The CAPS and the outcome measures highlight the areas where the interventions will make a difference, and I think we'll be doing that better and better as we get the inter-eye data more user-friendly. And it needs to be collaborative. Do the resident and the family fully understand and agree? One of the facilities I used to work at used to do a summary care plan and send it to the family, or have a MDT, or have a family meeting and have that family sign off the care plan. That's a hugely valuable thing for families of older people, to sit down and say, this is our care plan, what do you think? It's hugely valuable.